59-year-old patient who had a stroke in November 2019. No obvious cause beside of a stroke, of a PFO, and he has severe pectus excavatum. So the colleagues in the other hospital decided, well, we need, in this particular case, we need pre-procedural imaging, and they did an MRI, and I will show you this a little bit later to showing the problem, but they prevented from trying to close this. So next slide, yeah, okay, so CT shows right cerebral ischemic lesion, carotid duplex, nothing important, EKG, nothing important, Holter EKG, sinus rhythm, event recorder, also sinus rhythm, and then TEE and TTE, a typical PFO with right to left shunt and atrial septal aneurysm. And this was the MRI, and they thought, oh my God, the heart is so much compressed, we cannot do PFO closure. And that's why they referred the patient to us. Now we have Judith, the TE is in place. Yes. Let's see what you see on TE, please.
Just to confirm that the axis of the heart is a bit different due to the severe pectus excavatum. The atria are quite compressed, they are shortened. And the normal angulations are not in place anymore. So the PFO is, you can see it's a long tunnel, but very slim, 3 millimeters to 4 millimeters in diameter, but quite long.
How long is that?
At least 13
millimeters? Okay.
If I measure to here, so if we measure,
okay.
13 millimeters.
Catheters in the pulmonary vein. So any thoughts from you guys over there?
So let me pick on Mark. Mark Risman, welcome to this webinar. Mark, any thoughts so far from what you've seen?
Yeah, very long tunnel, obviously. Looks compressible. It doesn't look stiff. It looks like it's going to be very compliant. Good overlap with the secundum. So I think the majority of devices would be effective here. It looks like something that we can handle with the traditional devices.
Okay. Apostolos, what are your thoughts?
Doesn't look very difficult to me. I don't know. I was thinking that crossing might be more difficult, but
and any particular device preference or?
Well, I mostly use the Amplature, but I think the Gore device would work too here.
I think Dave will do with us. Dave, any thoughts? No, is Dave not with us?
Yeah, can I comment?
Yeah. Oh, Iqbal. Right. Yes.
Right. Number one. Oh yeah, I was going to say that, Horst, that I would, I balloon size, so I would balloon size this, and then depending on the size of the tunnel, if it was more than sort of 16, 17 opening up, might even choose an ASD device rather than a PFO device to close it. I don't know what you guys think about that.
Yeah, that's reasonable. Nilesh, what would you be telling Iqbal to do then? Balloon, or does he tell you what to do when you do the image?
So we don't tend to balloon size, but we do balloon interrogate these long tunnels because you can sometimes see how compliant they are by the configuration of the balloon. Because we already saw a case where with a long tunnel where the device kind of got stuck and we didn't manage to compress it nicely. But I think it should fit a nice soft device that conforms. The aortic root looked a little bit large, just maybe in proportion to everything else in that view.
Yeah, I agree.
And then also the right atrium, the geometry may be altered, by the pectus. So we'll see. It may be interesting. Well, it will be.
Just look at the aorta as well. PFO and then.
I was struck by the roof of the left atrium seemingly slightly compressed, and so I take care not to encroach upon the left atrial roof of the device, or use a device that something like the Gore potentially in this case.
It does look big. Does that alter your device selection at all? Anybody?
Not with this degree. The secundum looks long also, so I don't think it's going to have a relationship. I don't think it's going to interfere.
Yeah, the aortic rim looks very generous, doesn't it? I think it's just one of the other factors which is deforming this. So maybe when we get a device sitting in it, it'll look weird.
Okay.
We didn't see it just at the start, but often with these unusual tunnels, looking at the 3D on the left atrial side to see how high up it goes is a useful addition that Bushra and Nilesh like to do.
There you go. Nice job. He's got the right there.
So that's a very small PFO, huh? So,
any particular pressure you go up to with the balloon?
yeah, I measure the pressure inside of the balloon, and the pressure is now 10 millimeters of mercury. So basically,
Yeah,
I'm not stretching the septum, right? Yeah.
Right. And if you looked at the septum primum, although it's very long, it doesn't meet probably criteria for an ASA. It's not moving a lot. So the attachment between the primum and the secundum is probably pretty reasonable. That's why you're getting that very discrete tunnel appearance.
Can I ask a favor, Horst? I just worry that we might still be in the tunnel, which is longer, and one bit of the tunnel, which is a little bit narrower. If you advance the balloon a little bit more and inflate it to get a better sort of dumbbell shape, that would make me more comfortable that we definitely got out of the tunnel.
Well, the TOE should show you that, shouldn't it?
It's very difficult. It's quite small on my screen.
You see, it's moving up and down when
well
I
in the left
advance.
atrium.
So I'm far in the left atrium, I think. But you see,
I think if we are concerned that there is not enough space, then let's say, for example, an 18 millimeter cribriform device from an Amplatzer 18 millimeter cribriform device could be a good choice in this case.
I would. Can I say I would go for a 25. All PFOs, most PFOs are closed with a 25 Amplatzer, and an advice that Bernie Mayer gave me is that you always go for a 25, and when you pull back, if it comes out, you oversize. Nothing else. He doesn't believe in imaging, so we had a debate on that, but 25 or 30 would be my choice.
Well, a 25 PFO occluder or a 25 cribriform?
PFO occluder.
I do PFO occluder.
Okay. So, Horst, what are you going to do?
Yeah. So the bad thing if you use a big device in such a small PFO and a long tunnel is that then if it is not really sitting flat to the septum, it will obviously stay much more apart because it's bigger. So actually I tend to use a small device here, like an, let's say an 18 Occlutech, for example, and see how it sits. Because if it is pulled into the tunnel and not opening the tunnel, then it's looking a little bit nicer. If the tunnel is not so restrictive, then it doesn't harm. So let's go for an 18 Occlutech PFO.
It's totally reasonable.
What size did you measure on the cine?
I didn't measure because it was so small. It's probably 3 millimeters.
That's what the DE had.
Yeah. Another important question here is, should we close it if it's so small? That's another question.
Well, you've brought the patient in for closure for some reason, which was based on the history. So I'm assuming that you should.
I think it's the bubble. It's a degree of shunting when you're doing your Valsalva rather than just the size on ballooning, isn't it? That would be material.
Yeah, we did a study. I know Horst was quoting studies from the early days, so I'm sorry, I'm going to have to do that as well. But we did a study looking at PFO size and its relations to conductance by transcranial Doppler. And it was almost like a scattergram. You could have small tunnels with significant conductance. I think everybody knows that there's a large eustachian valve and things where the tunnel is more directed or the flow is directed to the PFO. You'll see that. Obviously, the bigger PFO is going to shunt more, but there are many smaller PFOs that shunt significantly by transcranial Doppler.
So we have a quick look at theory and see how having a stiff sheath across.
Paul, can I ask you another question?
Sure.
You've got an implantable loop recorder or link device in.
Yeah.
How often do you do that to exclude atrial fibrillation?
I never do it. The referring neurologists do it very often, but I never do it.
Okay, so I'm going to own up and say I've got a limit of about 2 weeks of monitoring in the absence of symptoms to exclude atrial fibrillation. Am I too conservative or too aggressive, team?
I think that's even more aggressive than I do. I mean, there are some special situations where I would consider that, for example, a patient with palpitations which occur every third week, and maybe an elderly patient who otherwise would be an indication for anticoagulation. That's a situation where I think an event recorder is needed. But
let me just ask Nilesh about the echo that we're seeing at the moment in the position of sheath and the septum. Nilesh?
Where is the sheath? Where it's gone through that long PFO tunnel, but 3D would be nice to show the sheath.
No, stay for a moment. Stay for a moment in the two-dimensional echo, and Judith, please turn the echo probe slightly around.
Yeah.
Okay, so yeah, we are definitely in the PFO tunnel and not in a fenestrated opening,
that's what I wanted to check.
Could be. Yeah, okay, that's fine. Now you can go for the 3D, and I will prepare the device. Okay, so many of you have seen this. This is the 18 millimeter Occlutech PFO device.
And the left atrial disc is 16, yes?
Yeah, 16 and 18 on the right side.
I think that this is small, but just to have a discussion.
Apostolos wants to put a poll up for the audience to join in. Is it too small or is it just right?
Okay.
While Horst is putting that up, that 3D, can we go back to that? Because that was a really beautiful picture on the left atrial side, just with the sheath tenting open the PFO flaps. If we just angulate the probe, we can begin to appreciate that it's just pushing a fairly narrow tunnel upwards.
Yeah, excellent picture there, yeah. So who would use a bigger device? If we could just try and volunteer. So
I just want to make a comment. If we really decide to size the PFO, then I mean we have to draw some conclusions out of it. And if we have in this sizing only 3 to 4 millimeter hole, then the conclusion could be, I think, to take a very small device. From this point of view, I don't see why we shouldn't go for an 18 millimeter device if we really rely that the hole is as narrow as we did it in sizing.
Yeah. Mark, what would you do?
I'd probably use a 25. I rarely used 18s, and that's just because of what we have available.
Iqbal?
Yeah, I've must say I've only ever once used an 18, so the 2325 Occlutech is my standard device, and that's what I would put in here.
Stefan?
I wouldn't have balloon sized this one based on the echo results, so I would have used a 25.
25. Dave, I don't know if you've been here all along.
Yeah, no, I mean, I would use the 25 just because I'm always worried about the device slipping off the septum secundum and ending up potentially in the tunnel. So I would, yes, similarly use the 25.
So it looks like we can't do the poll, but it looks like we've already got an answer. Because
25. Susan?
25.
25, okay. Well, there you are. Horst, you're using 18, so can we see the pictures?
Yeah, you can see it on the screen.
Well, it stayed.
Yes.
It's still connected, so it doesn't mean anything. But I think position looks good to me on angiography.
Yeah.
Let's do another cine here.
It's hugging the septum beautifully. It looks great.
And also on echo, also okay, huh?
Yep.
So then we can release it. Apostolos, can we release it?
I would like to see the aorta.
Huh?
Okay. Hold on.
The aorta view. That seems a long way away.
Yeah.
Yeah, looks good.
Yeah, okay, so I release it.
Feel free to release, Horst. Can we just get an explanation for that slightly unusual extra frond in the left atrium that I must say I don't normally see after a PFO closure? There's a little bit of excess tissue. and that we might be able to see on 3D once you've released it. And feel free to release. I don't think we'll change this device, but it just looks odd.
Yeah, it's it looks like it's part of the tunnel, right, of the septum primer.
Yeah.
But it's unusual to see it there.
That suggests to me that there may have been more than one exit point from the left atrial side, and you've gone through that rather than
You've gone through a fenestration.
Yeah. Yeah.
You may have gone through a small fenestration.
Yeah.
That's why it's sized small.
Yes, correct.
And the other thing I would do before release, but now it's too late, I do a bubble test just to evaluate.
Interesting.
What will you do with the bubble test, though? I mean, how will that help you?
Well, if you have a bubble test that shows a severe shunt, you may reconsider your implantation place.
But when you're attached to the cable, surely that can't tell you anything.
No, it does. Well, I get some information. It doesn't cost anything. It's just one injection.
Okay.
So, and
if
when
it makes you happy, keep doing it.
Okay.
I think we've got the explanation for why this looks so brilliant, and I think it was a long tunnel, but it went through a fenestration. It's left a bit of excess tunnel on the other side, which doesn't matter, and it's going to produce a fantastic seal. So great job.
Yeah.
It's like doing a transeptal puncture at the tip of
Exactly.
Yes.
Yeah. And I thought it's not a fenestration because I saw that the sheath was touching the septum secundum, and usually when it's touching the septum secundum, I think it's not going through the fenestration, but obviously there was a fenestration high up, let's say in the middle of the tunnel, and I went through that. That's what I believe was the reason here. But again, looks good.
Could be.
Okay.
Yeah.
Good.